Good morning, colleagues, and good afternoon, depending upon where you are in this world, or good evening. Thank you so much for joining the WHO webinar on Together for Health, We Stand with Science, Country Data and SDGs on Air Pollution and Health. We're very excited to have you here, and I would like to now turn. My name is Heather Adair. I'm the technical lead on air pollution and health, household energy and health at WHO. And we have a few housekeeping before we start officially. As this is a Zoom webinar, we have the camera and microphone are disabled for participants and only allowed for our panelists. When you do have questions and answers, and we hope you have questions and answers and comments, please add them to the Q&A or the chat to add them, and we will try to address them at the appropriate times. Also, please keep your questions relevant to the topic of the webinar. This is really meant to be a powerful information session to help share the important knowledge and information we're doing on WHO to track air pollution exposure and its health impacts. In case of technical problems, please feel free to ask for assistance in the chat in case you cannot hear, there's volume issues, or et cetera, et cetera. Also, please note the webinar will be recorded. Recording and slides will be posted on the webinar page afterwards. So if you missed a little bit, don't worry, you'll be able to listen to it again. Just a quick overview. As you know, I'm providing a bit of housekeeping and introductory remarks. Then we'll hand over to Mr. Bruce Gordon, who's the Director of the Department of Environment, Climate and Change and Health, One Health and Migration, for WHO to present some opening remarks, followed by a presentation by our Head of Data and Statistics at WHO, followed by Dr. Sophie Gumi, talking about how we engage with the formal SDG framework. Then we'll turn to Jocelyn Moth to talk a little bit about the work that they're doing in the Asia Pacific region and how they're looking at SDG data and looking to inform policy. And this is followed by some stories from the ground. We'll hear from Dr. Bin Mohadid, the head of the Environmental Health Unit in Malaysia. And then we'll end with a question and answer session, followed by some closing remarks. So let's get started. Over to you, Bruce.
Hey, well, thank you so much, Heather, and welcome everyone. I'm very excited to be here, and the reason is I feel for our department and for environment and health, and potentially across public health, the SDGs themselves, and specifically SDG monitoring, I've always felt can be our most important lever. And I think the reason is we do a tremendous amount of work at WHO when we think about guidelines and interventions and technologies, clean cook stoves, all the other things. But at the end of the day, the change that we need to see is really at system level, right? So we need governance, we need policies, regulations, and of course, a lot of investment to make the changes that we see need to happen. And that means political will. And political will gets shifted by accountability. And in my experience, and I'll tell you, I come from a water and sanitation background, but there's a tremendous amount of monitoring we do on that as well. And the countries that have made the most progress have had to actually shift billions and sometimes or hundreds of millions of dollars into the space. And they've done that, and I think in a large part because they understand where they're at. They understand, the benchmarks they often have with their neighboring countries. So this idea of trusted, credible data, underpinned by harmonized methodologies and definitions, all that good technical stuff can move mountains. So I think that's kind of why we're here today. Um, it's also kind of a world barometer, I think. And when we talk about status and trends, and if you try to tell anyone about the area of work that you care so much about, the first question is, how are we doing as a world community? And this is allowing you to sort of say, this is the urgency, and this is what the ambition needs to be. And I think as we kind of get to the end of the SDG period, it allows us to understand, okay, what can we do during that period? And then more importantly, potentially as we think about what happens after the SDGs into the future, the post SDG period, that's all informed by what we're doing and what we're going to talk about today and what Heather's already touched on. And I think certainly there's a great opportunity with this SDG 7 tracking report and the review of the SDG 7 and 11. I think they're being highlighted and looked at specifically at the HLPF in New York very shortly. So a great opportunity. And maybe just to close by saying, we'll hear more from my colleague on health statistics, but WHO measures a ton of health-related SDG indicators, and many of those in environment and health. They guide our strategy. So our global program of work 14, we call it. And a lot of the efforts that benefit health are from outside the health sector. And to kind of foster this kind of intersectoral collaboration between ministries and different, yeah, as I said, sectors, we need that kind of guiding light. And we're really fortunate to have the health-related impacts on air pollution, mortality, and things like wash mortality in the SDG 3.91 and 3.92. And this is all about trying to, kind of ensure that we have a clear and visible, transparent light on our target of reducing 50% the health-related impacts of air pollution. That's why we're all on the webinar today. So I really wish you the best of luck. And this is incredibly important stuff, and look forward to discussions, questions, and seeing this webinar. So back to, I don't know if it's you, Heather, or Paul or Jocelyn, over.
Wonderful. Thanks so much, Bruce, indeed. And there's a lot of connections in advancing indeed, and having strong statistics to move this forward. So this webinar is really, as you mentioned, we're really going to be looking at launching and presenting some new data for the SDG 3, 7, and 11. We're going to highlight how countries are involved in the monitoring process and spotlight, really look at what some specific regional plans using this data. So we're going to start with the first piece of the puzzle now, and we're going to transition to hear from Dr. Boshin Kao. He's a statistician from the Department of Data, Digital Health Analytics, and AI at WHO. And he's going to present us with the backbone of the statistics, really giving us the health data, the numbers that allow us to actually estimate the attribution to air pollution exposure and its associated disease burden. So we'll now hand over to Dr. Kao. Over to you. Hold on just a moment. We're having a little technical difficulties because Dr. Bao was not able to join us in person and sent a video. So we're just putting this up. Just a moment.
Hello everyone, my name is Bertrand Cao. I'm from WHO's Department of Data, Digital Health and Analytics and AI. Today it's my pleasure to present to you an overview of WHO's Global Health Estimates, which is WHO's tool to monitor global health and burden of diseases. Let me start with the introduction of what are global health estimates. Global health estimates, what we also call GHE, represents WHO's official comparable estimates of mortality and loss of health by country, sex, year, age, and cause. It reports on annual health outcomes for over 170 diseases and injuries for WHO member states from the year 2000 onwards. Currently, the latest available estimates are up to the year 2021. We are currently in the process of updating the time series to the year 2023, and we expect to release the updated estimates in the next 2 months. In general, GHE consolidates and harmonizes the best available data from multiple sources, including national vital registration data, which we use as a primary source for cause of death data. And we also draw on estimates from WHO's technical programs, from UN partners and interagency groups, as well as estimates from the global burden of diseases and other scientific studies. In estimating the burden of diseases, we apply a variety of demographic, statistical, and epidemiological methods based on the best scientific evidence available. Give you a bit more details. The GHE reports on disaggregated mortality and morbidity data for 183 WHO member states with population greater than 90,000, and the estimates are reported separately for men and women for years from 2000 onwards, and the estimates are available for 170 individual causes, which we group into 3 broad categories. The first category being communicable maternal, perinatal, and nutritional conditions, and the second being non-communicable diseases, and third is injuries. And the estimates are also reported by age groups, and start from 0 to 1 and 1 to 4 years, and then from there on largely 5-year age groups up to age 85 plus, which we use as an open age group. And we also report some data estimates for some related indicators as a byproduct of this exercise, and that include the assessment of completeness of death registration data, and life expectancy, healthy life expectancy, as well as years lived with disability and disability-adjusted life years as a measurement of the overall burden of diseases. And the GHE data has some important usage, including monitoring numerous health-related indicators that are pertinent to the Sustainable Development Goals and WHO's 13th and 14th General Program of Work. And those indicators include child and maternal mortality, premature mortality due to NCDs, suicide mortality, and mortality due to road traffic injuries due to homicide, natural disasters, and conflict. And the GHE data are also used as input data to serve as an envelope for estimating mortality attributable to risk factors such as tobacco smoking, air pollution, and wash. The GHE data is very critical for member states and WHO to understand the global health, its trends and shifts in main causes of death by region and by country. And it can be used by decision makers to guide policy making and resource allocation. The GHE data are also important inputs to WHO flagship publications, including the annual World Health Statistics Report and Global Monitoring Report for UHC. And now let me give you a quick walkthrough of the estimation process for the GHE. There's 3 major stages for the production of GHE. We start with getting input data. At this stage, we identify and extract data from a variety of data sources that meet our specified data inclusion and exclusion rules to make sure our estimates would have high quality. And the second stage is estimation. At this stage, we address the data biases and comparability issues. For example, the underreporting of cause of death and the misclassification of cause of death. By doing so, we can make sure the estimates would be comparable not only across geographic locations, but also over time. And we would also need to validate the estimation strategy to ensure the final estimates from the statistical modeling would be as close to the reality as possible. And we also generate uncertainty for each of the point estimates we have during this estimation process. And once the estimation are done, we would start our dissemination process, in which we would start with a country consultation to engage with member states and make sure the estimates would gain consensus from countries as much as possible. And once country consultation is done, we will also add a statistical clearance to ensure that there are no human errors in reporting the estimates on the official and public domain of WHO websites. And along with the estimates that will be published on WHO website, we will also provide the detailed methodology. The whole estimations process starts from estimating all-cause mortality, which we do separately for countries with good vital registration data and countries without good vital registration data. For countries with good VR data, the estimation are fairly straightforward. First, we assess the completeness of those vital registration data, and then we make adjustments for underreporting accordingly. However, for countries without good VR data, we draw on the input data from census from National Representative Household Surveys and other data sources, and we use the modeling approach to generate the age and sex specific estimates for all-cause mortality. For the estimation of cause of death data, we rely primarily on the vital registration data from countries where possible, with adjustment for incompleteness and misclassification of cause of death. And for countries without vital registration data, we use the global burden of disease study as a complement source to fill the data gap. We also produce estimates of burden diseases measured by DALI as part of the GHE enterprise. For the mortality component, years of life lost, we calculate those using the cause of death estimates we derived in the previous slides that I mentioned. And for years lived with disability, we primarily draw on estimates from the global burden of disease studies. Similarly, we also produce estimates for life expectancy and healthy life expectancy, which are important indicators for WHO to track the overall population health at global, national, and regional level. And this concludes my brief overview of the GHE source of data and estimation process. Thank you very much for your time.
All right. Well, thank you, Dr. Bao. This was very, very helpful. Again, this provided a good picture and snapshot into the basic, that background disease data that we need. And it really gave a good capture of how it is really deriving from basic country statistics that we're using. Really, this is homegrown data that we're working on, really consulting with countries to understand this background disease data. And that's shared across other risk factors as well. So it's really a common sense country agreed upon data set that really takes a lot of effort and time, but really organically grown in cooperation with the countries. So now, just a quick reminder, please add your questions to the Zoom Q&A because we are tracking them and getting ready to add them in later on. And so now we've heard the first piece of the puzzle, and that was the background disease rate. And so now we're going to transition to how to hear from Dr. Sophie Gumi about how we take this data and translate that into understanding the health impacts of air pollution specifically. So I would like to go ahead and hand over to Sophie. Over to you.
Thank you, Heather. Hi, everyone. So we will just now present you with the data on air pollution and health. Next slide, please. This is just an overview of the slides to come. So we will just show you how those indicators link together, how we are using one indicator to derive another one. We will also discuss the reporting process and taking a question about lesson learned about what we need to take into account for the post-2030 agenda. Next slide. So there are three indicators that for which WHO is custodial agency. Bruce Gordon has already highlighted that WHO is also responsible for a number of indicators outside the health sector, but that are used to calculate health or that are used to measure progress and well-being. So the first one is on SDG 3. It's on mortality from air pollution, from the joint effect of household and ambient air pollution. We have one on SDG 7, which is about energy. This is the percentage of population with primary reliance on clean fuels and technologies at the household level. And we have one on SDG 11, sustainable cities and communities. This is indicator 11.6.2, which is air quality in urban areas. Next slide, please. Environmental health pathway. It is quite important to remember that it's always very difficult to monitor at the exposure at individual level, and there are really an environmental pathway going from the source of emissions, which for air pollution we know that can come from multiple sources, from residential fuel use, from industry, from transport, from power generation, from agriculture, also from the land use aspect of cities and place in settlements. Those translate in concentrations, so there will be the amount of a substance in the air, but this is not necessarily equal to exposure. Exposure is really when the pollutant is in contact with a human being and the biological agent and in the organism. And then there is a concept of the dose because you can be exposed, but you cannot take the same dose. And depending on the dose, you will get health effects. So of course, all this process of estimating health impact has a lot of flaws and uncertainties. It is important to recognize them. However, in the absence of the best data, we use what we have at hand. And I think next slide. Now we will go into the detail of the SDGs. I don't know, Heather, if you want to present on the coming slide on SDG 7 specifically.
Sure. Happy to quickly jump in as this is I would say my baby to some extent. Yes, so SDG 7.1 is one of those ones that's very interesting because indeed we have to understanding it derives basically looking at household air pollution as it's a very substantial health burden associated with it. So we estimate around 2 billion people around the world are lacking access to basic household energy needs just for cooking alone. So our definition for this particular SDG, it's really an example of how the health and energy sector are working together. So the definition of the indicator itself is the proportion of people with primary reliance on clean fuels and technology, and in this case for cooking alone, because that's where the data was. So this data is really, we produce estimates annually every year for the number of people with reliance on clean fuels and technology. Interestingly enough, the clean is actually defined by WHO guidelines for indoor air quality household fuel combustion. So these guidelines provide technical recommendations based on health evidence that's being used to inform and policies within the energy sector to accelerate access to clean fuels and technology. So again, the guidelines define what can be considered clean. And the data themselves is derived from, we use input data. So WHO maintains the largest household energy database. This is a database that's updated annually with nationally representative household surveys and censuses, reporting basically, ideally, the fuel and stove technology. However, typically it's just the fuel and typically the primary fuel. However, WHO has been really working over the years to enhance our ability to estimate exposure and associated disease burden for the fuel and stove stacking that goes on in the home. Next slide, please. So as you can see, this is a bit of a trends. This data was just released for the 2024, and you can see that across different regions of the world, we definitely see an increase in the reliance on access to clean fuels and technology, except for there's one region which there's concerns, and that is in the African region. We actually see in the African region that there's actually an increase. The number of people gaining access to clean fuels and technology is outpaced by population growth. So you see an actual increase in the number of people who are relying on clean fuels and technology. This is helpful to help policymakers really concentrate their efforts on a particular region, noting there's also huge gaps in Asia, for example, and some parts of Latin America too. So it's not just about one region, but it's helpful to know where the trends are and where we can prioritize and learn from that. Back to you, Sophie.
Thank you, Heather. And now let's jump to the next SDG, the SDG on air quality in urban areas. So the definition of this in 5, population weighted. So it's quite a complicated title. Particulate matter is air pollutant that is actually a mixture of different things, and it's really an indicator it's a proxy indicator for exposure for air pollution in general, because a lot of different PM 2.5 can come from a lot of different sources, and it's also very much dependent on the topography and the meteorology. So it is really a key pollutant for which there is a wealth of scientific evidence for health impact. The computation method is modeled. So the reason is that there is measures of particulate matter 2.5, but not every country are measuring it, and this is the reason why in order to have a really comprehensive data set, that this data is modeled. I will come to that later. The reporting period here is a bit less frequent than for SDG 7. This is every 2-3 years. And this indicator is used as an exposure to ambient air pollution. Next slide. So in the next slide, we should be showing the type of data that we are using to model this indicator. And this is actually an important piece. This indicator is based on ground level measurement that WHO is compiling from official sources. So we are really looking at official monitoring network in countries, and all this data is compiled in the ambient air quality database. However, because this is not enough and because there is not enough information for each country, we are also using a satellite and some reanalysis. This is also a complicated word, but this is a data set that is provided really directly by WMO, by the World Meteorological Organization, with who we are closely working. So they are using a different satellite data, and they have been creating a model based on all this different data with reanalysis to really ensure this data is comprehensive. And because this is population weighted, we are also using, of course, some population data. So the idea is really to have a satellite data that is available for the entire planet, and we calibrate all this data with a ground monitoring station so that we can be sure that this is more or less correct. And the model is a statistical model. The output of this model, it provides two different things. The first one is a concentration for PM2.5, so really basic concentration at grid level, 11 kilometer. And we can aggregate this data at country level once we have overlaid a population grid. And for this population weighted annual average, we can have it for the country, but we can have it at city, at town, or at rural level. Because now there has been a new definition since a couple of years, established by the statistics and different UN entities and partners to define what is a city, what is a town, and what is a rural area. And this data set is available for years 2010 and 2023. Next slide. So this is the result. The results are positive and negative. Overall, globally, air quality has improved since 2010, but progress has stalled since 2020. Well, it's quite flat since then. In 2023, which is the last, the latest data point we have, the number of people exposed to the highest WHO air quality guideline interim target was 13 times higher than in low and middle income countries than in high income countries. It means that it remains a huge inequality both and at what level on this. Next slide, please. Okay, now comes the most important one, the health impact. So SDG 3.9.1 is mortality attributable to air pollution. So the definition here is we are providing a age standardized mortality rate attributed to both ambient and household air pollution. So why age standardized mortality rate? Of course, different countries have various population structures, and some diseases are more prevalent in some age groups. And in order to be a comparable estimate, we are using this age standardized mortality. The computation method here is estimated, meaning that we are not modeling it, we are using different information to calculate it. Here, the reporting period is every 2-3 years. We are basically dependent on the presentation that we heard before from Dr. Cao on the global health estimates, because we need the global health estimates to calculate the mortality attributed to air pollution. And yes, this indicator is using SDG 7 and SDG 11 that we just heard about as proxy value for exposure. Next slide. Okay, this is an important piece as well. So this is just to remember that we are using SDG 7, clean household energy access, or actually we're using the polluting fuel use to calculate mortality attributable to household air pollution. We do the same for ambient air pollution. We use air quality levels, and we calculate mortality from ambient air pollution. And once we have those two figures, we are calculated the mortality from air pollution. And next slide, but I think the next slide, for the sake of time, I will not go into the detail, but just to say that we cannot add those two because they are not completely independent from each other. So here, again, just as a recap, so for this, the input data here is the global health estimate, the SDG 7.1.2 and SDG 7.11.6.2 as exposure, and we are using epidemiological evidence to extract relative risk. So the output is we have deaths, that is years of life lost or years of life lived with disability as described by Boschen. This is metrics. But we sex and for the period 2010-21. And just to note that 2023 data will be soon available as well. On the right side, you can see the graphic with the age standardized mortality. As we can see, there are some regions that are more affected by others. And also the disease distribution is also different depending if this is there is more high income countries or lower middle income countries in the region. And again, there is a huge regional disparities with high-income countries much less affected than high-income countries. Next slide, please. You can go to the next slide. We will just skip this one. I will not go into the detail for this one. Okay, country consultation. This is an important piece of work because we get the data from, okay, once the graph is full, okay. So basically, UN Statistic Division is responsible for the indicator. We get a country focal point in each countries. We have a focal point on the National Statistical Office. However, WHO also contact every country to ask for a technical focal point in Ministry of Health, Ministry of Environment, or Ministry of Energy, with who we can then exchange about air quality data and about household surveys to see if what we have collected is really comprehensive and if there is any missing information that would be very important. Once we have that, we do the calculation, we share with the countries, they can have a look, and once this the time has passed, we just report back to the UN Statistic Division. And the fact that WHO is in charge of this of some indicators outside the health sector is an important opportunity for health sector leadership because it really can foster multi-sectoral coordination within the country. Next slide. And the next slide is about how the country data feed into the country, into the SDG. And this is just a recap to really strengthen the message that there is the data from the countries really directly feed into the SDG. And the data is extracted from mostly publicly available sources for each different indicators. Next slide. Okay, this is important because as Heather has been mentioning before, the WHO air quality guidelines have been instrumental to define what clean fuels and technologies are, and also to define what cleaner is and how much this can impact health. There are normally more bullets in the slides. The second bullet is an important one is to say that WHO is monitoring exposure and health impact, and this is quite important to really define evidence-based policy and programmatic planning. And finally, another point that is very important is that mainstreaming health in different sectors is important. And to mainstream health, we need to have some tools to really to calculate and measure health impact and economic assessment. And therefore, it's important to have those tools and to disseminate those tools and to really strengthen the use of those tools. And all of this, just to say that, as Bruce has also mentioned at the beginning, that it's very important, this data, to really track and monitor the WHO's proposed target of 50% reduction that has been proposed last year at the and it will be instrumental to measure this target. Next slide. Just a message that this is a global collaboration. WHO has been working with the World Meteorological Organization and a wide variety of research groups, Daniel Tong and his team in the US, but also Matthew Thomas at the University of Manchester and Oliver Stoner in the University of Glasgow, and we thank them very much. Next slide. And finally, here are the QR code where you can get much more information on those SDGs. And with this, thank you very much for your attention.
Great, thank you so much, Sophie. That was really great deep dive into how we derive those exposure statistics and burden of disease for air pollution, building off Dr. Bochin's health estimates. So now I have the pleasure of introducing our colleague from the ACE Center, Jocelyn Mock, who is a technical officer at the Asia Pacific Center for Environment and Health in the WHO Western Pacific region. And he's going to help us look at some of the long-term trends in SDG data that's important to track and how that can impact policy. So over to you, Jocelyn.
Thank you so much, Heather, for the kind introduction. It's my pleasure to be with you today and to speak about the long-term trends of air pollution for the Western Pacific regions. And I think you get that the main message of my presentation is already in its title. As highlighted by my colleagues, what get measures get managed, and the SDG indicators provide a common language that allows countries to track progress, compare trajectories, and understand whether investment in clean air and clean energy are delivering health benefits. So what I will be presenting today at a glance, a quick introduction to the three key SDG indicators and their significance for the health sector and beyond. I will also be presenting the long-term trends in air pollution in the Western Pacific regions. And finally, I will be linking the SDG indicators with the work that we are doing here at ACE on strengthening air quality standards with a new ACE publications, and finally some key concluding remarks and welcome way forwards. And so first, introduction to the three SDG indicators that was presented in depth by my colleague Sophie Gumi. I just wanted to quickly remind the importance of air pollution as under the risk factors for both acute but especially chronic health effects, whether we are talking about respiratory outcomes, cardiovascular diseases, but also in utero exposures and how it affects negatively pregnancies, metabolic dysfunctions, and brain and psychiatric disorders. And beyond this, and beyond some illnesses and mortality, we are also talking about some considerations around the societal impact of air pollution, especially in terms of equity, but also in terms of quality of life and the years spent in illnesses for people. And essentially, air pollution beyond premature death and disability is leaving no organs intact. I will not go further. You all have heard quite a lot on these three indicators already, on how they are calculated, how they are using methodology that allows for comparable measures across countries, and how the data that are used are also data that are trusted by government and all the stakeholders that are using them for their work. So in the next few slides, I will be presenting the quick trends, long-term trends of air pollutions in these three dimensions through these three indicators for the Western Pacific regions. And so the first one is indeed the exposure to PM2.5, which has fallen quite a lot over the last decades, although gains may be slowing down, and you can see in 2023 a small increase, which is also an increase that we observe worldwide. But the decline, nonetheless, is extremely important. It fell from 45 to 50 micrograms per cubic meters between 2010 2013 to 24 to 27 micrograms per cubic meters in 2022 2023 in most countries, which is roughly a 40 to 50% reduction in exposure over the periods. And that's quite remarkable. This is a very good example of how important it is to look for long trends in air pollution exposures, and the rest of the two indicators will also show why. Likewise, the reliance on polluting fuels has fallen dramatically, but the transition is not yet complete. You can see on this slide 2 decades of quite a lot of progress, falling from 60% of people using polluting fuels and technologies to 12% relying on polluting fuels, which is a 48% point reductions and around 80% relative declines. And if you are quite anal, you can see that actually this is the reverse SDG indicators, because the indicator itself actually track access to clean fuels. But I wanted to show you the decrease rather than the increase of clean fuels. And so finally, for when you combine these two exposure to pollution, both household and in ambient, you can derive the mortality related to air pollutions. And you can see on these slides, slightly less, but still a decrease in air pollution mortality. It's still significant. Air pollution has fell from 3 million people dying prematurely in 2010 to 2.3 million in 2021, the latest available estimate at the moment, which is roughly a 15% decrease. And this, plus the two previous slides on the work on clean fuels for the last decades and the work on exposure for the last decade, really demonstrates the cumulative benefits of cleaner energy, improved air quality management, and public health intervention. Soon available, and we are very happy with this collaboration with WHO headquarters led by the colleagues in HU in Geneva. You will be able to find a summary of the situations in the WHO Western Pacific regions at the regional level on air quality and health. And this snapshot will contain, it will be soon launched. And this snapshot contains some very nice infographics and summary on the exposure and impact of air pollution on the people, including details on the population structures. And you can see that the vast majority in lighter colors is living on the right side in the graph in areas with higher air pollution than what WHO recommends. Likewise, you can see on this nice graph access to ground monitoring network, but also the level of annual fine particulate matters in 2023. This will be soon available in the WHO website. I wanted to make a quick link, and that will make a nice transition with the work that is done at the country level that will be presented by the next presenter, Dr. Norlin. On how this work on SDGs can be connected to broader work in the policy sectors beyond tracking. The real benchmark for health is very much the WHO air quality guideline. They set what WHO recommends as safe level of air pollution, actually not technically safe, but safer level of air pollutions. And at the same time, we need to be grounded into reality. And that's why last year, countries at the World Health Assembly agreed on a voluntary target to reduce the mortality due to anthropogenic emissions of air pollution by 50% by 2040. This is where the policy gets into actions. And when you take these two combine, one of the cornerstone of air quality management is air quality standards, numbers that are binding. Not the case for the air quality guideline, which has recommendations from the WHO. And we undertook recently in ACE and in the Western Pacific region a review of the 38 countries and member state situations vis-à-vis air quality standards and comparing them with the guidelines and calculating what would be the benefits of achieving the air quality guidelines levels. And so the key finding is very much that none of the countries are fully aligned with the level recommended by WHO, which indicate a need for regulatory improvements, but also, more importantly, enforcement measures to protect the population from exposure to air pollutions. Half of the countries and areas in WIPRO have established air quality standards for at least one key pollutant, and that roughly covers 99% of the populations. While that seems quite a lot, again, these numbers can vary quite drastically and can be quite much higher than what WHO recommend as safer level. Without much surprise, high-income countries are more likely to have air quality standards in place. But more importantly, for policymakers, decision makers, we have also calculated with the help of headquarters what would be the mortality avoided if countries in our regions would reach the level of 5 microgram per cubic meters for PM2.5 at the annual level, and which is at the level recommended by WHO, and we used it as a counterfactual, and that led to the calculation of model estimate of 1.1 million deaths avoided annually, which is extremely high. And that's probably the key message of this report. And you can see here by countries the reductions of mortality. I will quickly move I just wanted to highlight that long-term trends in SDG data reveals whether policies are translating into population health gains. Short-term fluctuations, such as the one from 2023, can be misleading, and only sustained trends shows whether countries are moving toward cleaner air, lower exposures, and fewer premature deaths, moving beyond policy cycle. More than 1.5 million people are dying annually in the regions due to ambient air pollutions. And reviewing air quality standards together and in hand with a health impact approach provided a powerful narrative for change thanks to the SDG framework. 3 quick reasons to why SDG data are essential for decision maker: tracking impact and not the activity that are done itself, protecting continuity across political cycles, which sometimes are way too short to show the benefits of environmental and health policies, and finally supporting accountability and investments, as highlighted by Gordon Bruce during his presenting remark. I will close on this. We just launched 2 weeks ago 2 new initiatives in the regions that are closely linked to the SDGs in terms especially on data availability. The first one is socializing the idea of a regional roadmap on action plan on air quality and health, building on the global and regional framework already in place. And the second one is initiating a regional community of practice on health impact assessment of air pollutions, and the availability of data and the work that is done in the data division at the country level is extremely important so that the input data for health impact assessment is available. I will stop here and hand over back to Heather. Thank you so much for your time. 감사합니다.
Wonderful. Thank you so much, Joss. That was great. It's really nice to really have a kind of a closer look at a specific region. So we've gone from these global health estimates, we've gone down to one risk factor, we've gone into how it's looking at the region. So now let's go further into how we can look into a country to really see at how this SDG data is impacting things. So before transitioning, though, I would like to highlight that we are trying to respond to your Q&A questions, and we will do our best to integrate some answers in our responses and in a timely fashion. So thanks for being engaged, and we encourage you to keep sending those in. Okay, now, as I said, I have the pleasure of introducing Dr. Nolan bin Mohammed. He's the head of Environmental Health and Climate Change Sector, Disease Control and Division at the Malaysian Ministry of Health. And we're going to look at how SDG monitoring is happening in his country and influencing decision making. Over to you, Dr. Mohammed.
Thank you very much, Heather. And of course, thank you very much for the opportunity for sharing the Malaysia experience in terms of monitoring the air quality as well as the SDG indicator related to the attributable death due to air pollution. Well, can you move to the next slide, please? In general, these are the foundations, the main important policies and regulatory frameworks that guide government of Malaysia to improve air quality over time. The first one is Environmental Air Quality Acts, Environmental Quality Clean Air Regulation, National Policy on Environmental, National Climate Change Policy, as well as the National Energy Transition Roadmap. All those policies are interconnected to each other, and it's very important for us to go and look into it. Next, please. One of the very important things in managing air quality is that we need to really understand the main source of air pollution in the countries. So we are quite lucky that we have a continuous air emission inventory management system so that we can yearly analyze the main source of air pollution. As you can see in the slide, in Malaysia, the main source of air pollution will come from the power plants, motor vehicle industries, and so on. And most of the major pollutants like particulate matter, salt, NOx, and CO2 will be analyzed on a yearly basis to see the major source. And in general, you would say that these are the main major sources for air pollution in Malaysia. Power plants, motor vehicles, industries, and probably a little bit others, which is including open burning. Next, please. For monitoring stations, we have a continuous air monitoring station all over the nation. In total, we have 65 continuous air monitoring stations whereby it's sending data on hourly basis to the central data system. And we have manual monitoring station, about 14, and we do also have a monitoring station which is mobile, depending on the situation where it's occurred, and we will deploy to the location needed. On top of that, we also have quite a number of meteorology station, monitoring station, in total more than 400 stations to complement the continuous air quality monitoring station data. And very important is that now we already have environmental air quality monitoring whereby it will systematically receive data from each monitoring station and will be analyzed at the central level. Okay, next. With regard to the parameter monitored, most of the criteria pollutant, we monitor it continuously at the at least 65 monitoring station with representing the industrial area, urban, suburban, rural, as well as the background data. But on top of that, we also monitor other parameters such as VOCs, mainly BTEC, benzene, toluene, ethyl benzene, and xylene, as well as heavy metal and the polycyclic aromatic hydrocarbons. And in terms of air quality standard, we have a few interim standard, which is revised over time to a better quality standard. Okay, next, please. This is quite new for Malaysia, and the air quality forecast application, where it was launched in March this year. And this is quite interesting for us because we can see the source of pollution, and this application able to predict 5 days ahead for us to plan and prepare whatever is needed to do. And this application able to predict for a few parameters, for example, PM 2.5, PM 10, ozone, SO2, and O2, as well as the black carbon. And the application able to see two domain. First one is for Malaysia, whereby we can zoom into the Malaysia scenario, and we also can choose source East Asia domain, whereby we can see the source coming from neighboring countries or not. Okay, next, please. And this is a very important policy that will drive major driver for cleaner air in the future in Malaysia. The first one is the national climate change policies. The second one is national energy transition roadmap. And these two policies are interacting with each other. And of course, we are linking the climate change policies, energy policies with the air quality management system. And you can see here, quite in line with the emission inventories, saying that the energy and transportation is domains of greenhouse gas emission. If you can see in terms of the sectors and key drivers, renewable energy is one of the very important element, whereby one of it, as I mentioned earlier on, coal power plant is one of the major source. In this roadmap, we are going to phase out all the coal-fired plant in stages, and by 2050 there will be no more coal-fired power plant in Malaysia. And the renewable energy will take over in terms of energy supply. And the second component, which is also very important, is the green mobility element. As you know, the vehicle emission is another one that's really contribute to the air pollution in Malaysia. With this policy, we hope in the future the source from this vehicle will be improved a lot. Okay, next please. In terms of cleaner fuel standard, we are moving toward a better standard since many years back. And of course, now for Euro 5 M standard is already nationwide available. Euro 4 standard for petrol is also nationwide available. And for the Euro 5 petrol standard will be rolled out in stages starting next year. And another issues is that the management of peatland in the country, because peatland burning is always difficult to control because the fires is under the earth surface is very difficult to be put out. So one of the innovation created by the government is that to create tube well for supplying the waters, and will be used to flood the area so that the water can reach deep into underground to put the fire out. Okay, this is very important and give a very important outcome to the Malaysia in terms of the peatland fire burning, and the distribution is quite available nationwide. Okay, well, next please. Okay, from monitoring data to health impact and decision making, of course, we are tracking the SDG 3.9.1, as well as we use the data for health risk assessment to give feedback and input to the agencies. Okay, next, please. For household air pollution, we are quite lucky that we are almost there. We are almost 100% achieving the access to clean fuel and technology for cooking. So this is something that very important for Malaysia as well. And for that reason, at the country level, we do not specifically estimate attributable death due to household air pollution because we are almost 100% there. Okay, next please. And for the ambient mortality due to ambient air pollution, we are working together with the agencies using the ground level data, as well as the mortality data from the fire diseases to estimate the attributable death. And of course, we are using WHO air quality, AQ plus to estimate the death. And this is very helpful for us. We've restored, it helps a lot to estimate the mortality. Okay, next. And here just shows some result from our local estimate. The important is that it shows reductions, not so much on the numbers, but the trend is much better to see. And we can see that for all 5 diseases, there's some showing some reduction. Okay, next please. And we do also conduct health risk assessment, especially for we all see group of pollutant, especially BTEX. This is very important because, as you know, that we don't have ambient quality standard for BTEX. Then we need health risk assessment to see the impact of it and create and provide feedback for the government to take action in terms of it. Okay, next. And not to forget about the acute episode of poor air quality, which always hit us, especially during the drought season because of transboundary haze and so on. As you know, the typical question asked in this country is actually when to close the school during haze and when to stop the sport activity or game when haze strike. So this is quite difficult to make decisions sometimes, but the people on the ground always asking for advice from the Ministry of Health. And for that reason, we are working together with the government agency and conduct heart rate assessment and create a threshold for decision making on this aspect. Okay, next. Well, for next SDGs priority, of course, we are strengthening our monitoring networks, enhance air quality forecasts, review. We are currently under review EQA as well as clean air regulation, assess health impact of quality and heat. This is another important issues, heat and interaction, heat and equality. And we also mainstreaming planetary health action in all sectors, healthy cities approaches, green spaces and equality. And of course, roll out of implementation for Euro M5 standard in stages and green mobility. With that, I think that's all from me. And before I end, I would like to thank all my colleagues from Department of Environment, Meteorology Department, as well as others colleagues for helping me in this presentation. Thank you so much.
Wonderful. Thank you so much, Dr. Nourlin bin Mohammed. This was very, very useful and great to see it happening in Malaysia, really using that data to translate the policy action on the ground. Really exciting. Thank you.
Welcome.
Great. And we hope that other countries can follow similar patterns. And this is something that's really helpful about these webinars, is it really is an opportunity to share knowledge and experiences to really hope that we can really influence other actions across, because really air pollution is a collective problem for collective action. So we all need to be working together. I know we're running a bit late, so unfortunately, as with always often the case in these question and answers, we're not necessarily going to have time to go through it. However, just to, we're able to go through this webinar and highlight, some of the key health impacts associated with air pollution exposure, such as ischemic heart disease, chronic obstructive pulmonary disease, lung cancers, pneumonia, and stroke. So these are very important diseases for which we quantify. There's a large amount of other emerging diseases that are also we're looking into to quantify moving forward as we synthesize that epidemiological data. So this is really important. And also to flag, we are working with other agencies to really collect this data, because we are one UN system here to serve countries and support them the best we can. So as alluded to, Sophie, for example, on the ambient air pollution works closely with World Meteorological Organization, WMO, and other agencies like UNEP. And we in the household air pollution side, we're working very closely with some UN partners such as the World Bank, the International Energy Agency, the UN Statistics Division, and the International Renewable Energy Agency, and the International Energy Agencies. We work a lot with these other agencies because it's important for us as the development community to work together to support countries the best that we can on the ground. And just one more thing to flag, we are capturing all the questions that we can. We'll circulate the resources to some of the key questions that you guys have asked post webinar. So please stay tuned and look out on your email for those information and resources. And to also flag, in case you really had a great time and you want to watch this or experience this webinar again, we are going to have episode 2 this afternoon starting at 4:30 Central European time. If you care to tune in, we'll be having a similar run through of this information, but you may get some other details if interested. So with that, I want to thank you for your time, but I'd like to now close and turn to my great boss, Dr. Dermot Campbell-Landrum. He's the unit head for climate change, air quality, energy, and health unit at WHO headquarters, and to give us a few closing remarks. Over to you, Dermot.
Thanks so much, Heather and colleagues. Can I just check you can hear me? And I prefer colleague. Thanks, Heather. But yeah, I'll keep this short because I think you've already had a huge amount of excellent content. And I think it shouldn't be lost on anybody who's joined this webinar just how important this is. Air pollution is the biggest environmental health risk factor that we have. It's right up there with any health risk factor that we have. And we know that the transition away from polluting fuels, the transition towards cleaner practices, will save many of the millions of lives that are currently lost to air pollution. And it's those same interventions which will also are also helping us to get on top of the climate crisis as well. So this is obviously a hugely important issue. And the data and the monitoring against the SDG targets is absolutely central to that. You can't do anything without the best science available. And we have, working with countries around the world, been able to get big commitments on addressing air pollution. The commitment to reducing by 50% the health impact of air pollution is a huge commitment, and it is possible, providing everybody stays on track. So the kind of monitoring that you've heard about today in relation to the SDGs, also in relation to WHO's current general program of work, we have the air pollution indicators there as well, is absolutely central to that. So you've heard a lot about the monitoring against the SDGs, but you've also, I think, heard a lot more in this webinar. You've also heard the reference to WHO's normative work on setting guideline values, because it's one thing to track the values of air pollution, but it only means something if you're able to compare that to what safe is. I sometimes say that giving just a single number like that is like saying, well, I watched the football match last night, Morocco scored once. You need to know whether that was good or not. You need to know whether that was better than was needed to beat the target. So WHO is also absolutely central to setting the guideline values for air pollution that countries need to aim for. And I was also say it's been brilliant to hear from countries as well. So the examples from Malaysia, talking directly about how they're implementing this kind of science in their own work, connecting it directly to national policies is obviously the thing that actually makes the difference in driving down these values. And finally, also to hear some of the good news as well, that there are parts of the world where there has been real progress in reducing air pollution, saving those millions of lives that we're able to save if we can drive this forward faster. So thank you hugely for your attention. Thanks to the team that is behind the webinar, but more importantly behind all of this work. As Heather has just said, you can tune in again to the similar webinar later today, but this is also part of a webinar series. I'm hoping a colleague can post the link to the webinar page in the chat, because we would hope that you will stay with us on this journey. So thanks once again for your attention. I look forward to seeing perhaps some of you later today and in future webinar series. And with that, I'll close the webinar. Thank you very much.
Thank you all.
Thanks, everyone.
Thank you, everyone.
Thank you.